Okay, we're going to try lecturing over Chapter 7 again and get it on YouTube, and then eventually put the link on D2L for you guys. Because I will not be lecturing this, and you do need to view this recording before Thursday. You will be responsible for this information. So let's begin. So from the beginning of our program, I have stressed the importance of patient education. It is not only those spontaneous teaching moments that I've mentioned many times, but it's the formal instruction that young people need when they're going through pregnancy, childbirth, and of course beyond. There's lots of opportunities available to couples, from cesarean birth to exercise to infant care, grandparent classes, sibling classes, and even childbirth classes for the adolescent, because they do have special needs. They are probably not going to maybe relate as well in a class of a lot of married couples. And so having a class just for adolescents and attending to their special needs that we've already talked about before is very important. And we know that teen pregnancy, even though the teen pregnancy rate has decreased over the last few years, it continues to be significant, and especially even in the United States. United States has one of the highest teen pregnancy rates in the industrialized world. From an organization or website, teenpregnancy.org, they estimated that 8 in 10 of these pregnancies were unintended, and 81% were to unmarried teens. The importance of childbirth classes, or any of these classes, of course, is to help prepare the couple or the individual for having the baby, raising the baby. It's this information that we share with the mom and significant other or family that helps them hopefully to minimize or alleviate some of the fear and anxiety about the whole process. And we've already talked about, when we talked about the 4 powers, or the 4 P's, and how psyche really plays a big part of how the woman is going to cope with labor. If we can help reduce or minimize her anxiety and fear, this will in turn hopefully reduce some of the pain that she's going to experience. Exercise, of course, is very important in childbirth. It's not so much the triathlons or the Ironman exercises, but it's the conditioning exercises, the pelvic rock, tailored sitting, shoulder circling. All of these, again, help the woman to be able to relax during labor. It also helps with that low back pain that many women feel in late pregnancy or even during their labor. There's also a variety of non-pharmacologic techniques that may aid the mom during labor to help her to relax, such as skin stimulation, massaging of the feet, diversion or distractions, breathing techniques. All of these are a part of helping that mom during her labor. Pain, right? None of us do. We know it doesn't feel good, and that anticipatory pain can be very distressing, just as much sometimes as real pain. As a nurse, we cannot feel that woman's pain. We must be empathetic to their complaints and concerns. We also need to be supportive and help mom and the couple through their labor using the various techniques that they have learned in their classes. So we're just as much of a coach and supporter than their significant other. So the way childbirth pain differs from regular pain or surgical pain is that it is part of a normal birth process, and moms need to understand that, okay? Couples need to understand that. We typically, as a woman, we have several months to prepare for that pain management. research or read about the different non-pharmacologic and pharmacologic pain methods that are available to them, and be able to choose. Okay, and it's also self-limiting. It rapidly declines after birth, except for the pain from maybe an episiotomy or a laceration or a C-section scar. It's going to go away. It's not forever. And a lot of times if people can identify, okay, this is these are some things I'm going to feel, I'm concerned about them, but these are things I can do for that pain and the discomfort, and knowing that it's not going to last forever also affects how we feel about it. So some factors that influence the labor pain. Pain threshold. I know y'all have already talked about this probably in the summer in basic nursing skills. It's also called pain perception. The pain threshold or pain perception is the least amount of sensation that a person perceives as painful. This is usually fairly constant. It may vary a little bit, but is usually pretty constant. Pain tolerance is the amount of pain one is willing to endure. How much are you willing to endure when you're going through pain? It can change under different conditions. If we're sick, that may affect how we're tolerating. If we're under a lot of stress, that's going to affect how much we are willing and able to tolerate. So our responsibility, as your book states, is to modify as many factors as possible to help the woman tolerate the pain as best as she can during labor. So you've learned also through maybe anatomy and physiology as well as basic nursing skills about the gate theory. Pain is transmitted through small diameter nerve fibers. But when large diameter nerve fibers are stimulated by such things as massage, palm and finger pressure, heat and cold sensations, these will interrupt those impulses that are trying to get through the small diameter fibers and essentially close the gate. That's why in childbirth classes we teach about massaging, effleurage, counter pressure that will help alleviate or minimize some of the pain. Also, endorphins. These are similar to morphine. The levels of endorphins increase with pregnancy, and they actually peak during labor, and that's a good thing, okay? And that can explain, or does explain, why many women only need small doses of narcotics or anesthesia. They don't need as much as someone that doesn't have that increased level of endorphins. And then there are maternal conditions: cervical readiness, pelvis, labor intensity, and fatigue. We've already talked a little bit about the changes that the cervix goes through before true and active labor may ever begin. Remember, effacement, okay, the thinning out of the cervix, okay. If a woman has not effaced before actual labor begins, it just takes more to get that cervix to thin out. And it takes more or longer for that cervix to dilate. So cervical readiness plays a big part of pain. The pelvis, the size and shape, is a huge influence. Any abnormalities may cause the labor process to be longer and more tiring for the mother. Fetal presentation and position are also a factor. We talked about LOA, ROA, OP, those positions, okay? When the fetus is vertex presentation and in the correct position, this helps with effacement and dilation. Any abnormal position can apply undue pressure in the pelvis, causing more discomfort for mom. And the example would be occiput posterior, when the occiput of the fetal head is pressing against her sacral and coccyx area. Labor intensity. Your book states the shorter, more intense labor a woman has, the more pain, whereas the labor which is more gradual may not be as intense, and she's able to work up to dealing with that. Fatigue. When we're tired, we're stressed, we are less able to deal with pain or able to cope as well. This is why women, while pregnant, need to get the proper rest they need so that fatigue does not play a major factor during labor. It is important, as the nurse, that we explain and moms are taught about these non-pharmacologic methods of pain relief, because all the medicine in the world will not take all the pain away. But hopefully it will help them relax enough to be able to use the non-pharmacologic methods to help them through those rough times. It is also important to utilize these methods, especially during early labor, because until a woman is in good labor, many physicians will not give medication or anesthetics because it may stop or slow down the labor pattern. Okay? So advantages to non-pharmacologic. Well, there's no harm to both mother and fetus. It does not, advantages of using them doesn't slow down the labor. And there's no risk or adverse effects. The limitations, as stated, these need to be learned. Okay, this is not something mom can walk into labor room and say, I'm going to breathe through my contractions. Some can, okay? But the majority of women are going to struggle with that, and to be able to relax enough to be able to breathe and use diversion and other techniques to get them through. You can teach someone that is not prepared, but it is much more difficult, especially if they come in active labor. Their focus is different, okay? So our role as a nurse, if mom has attended or hasn't, okay, is to, of course, build on what they know, build on their knowledge, and guide them through it. The methods of childbirth preparation that your book refers to is the Dick Reed method, Bradley and Lamaze. Reed was an English physician who introduced the concept of fear, tension, pain cycle during labor. He believed, of course, that fear contributed to pain, and we've already talked about that. Education and relaxation were techniques he stressed to help interrupt the cycle of fear. Bradley was first called husband-coached childbirth. He was the first to use the father as an important part of the labor process. He used a lot of slow abdominal breathing and relaxation. And then Lamaze is considered the psychoprophylactic method, using mental techniques that help condition mom to respond to contractions with relaxation rather than tensing up. So one of the diversions I used in my labor with my daughter was a picture of my son being held up for the first time. It gave me a focus on what was going to be the outcome of that pregnancy of a beautiful baby. And so that was my focus, and I used counter pressure in my back, or my husband did, and that helped a whole lot in getting through my labor, because I wasn't able to have pain medication or an epidural because I was so far along and moving so quickly. So promoting relaxation is the key to all the methods of pain relief for mom, no matter if non-pharmacologic or pharmacologic agents are used. As the nurse, we're there to help adjust the environment, to make it more conducive for mom, to help her relax, maybe turning off the TV, dimming the lights, using other techniques that she has learned in her childbirth classes. We also need to help reduce her fear and anxiety. By doing so, we're going to, in turn, help her to reduce her pain level, or her pain. What is one way to help reduce mom's fear? Of course, explaining procedures and educating what we're doing. And so many times moms don't even realize how tense they are. It is our responsibility to guide the partner to help mom relax by changing positions, massage, guided imagery, such as, okay, let's relax your right arm. And by slow massage or very gentle massage and rubbing, we'll do that. And then we're going to relax another part of the body. and so on and so forth. Effleurage. This actually stimulates those large diameter nerve fibers that can block or close off those impulses that are trying to get through those small fibers, okay, by stroking her abdomen in circular motions. Sacral pressure for that back labor. Thermal stimulation, whether it's heat, a warm blanket, a glove with warm water, warm shower, a cool cloth to the face. Any of those may help. Positioning, frequent positioning to help relieve muscle spasms and tension. And then, of course, diversion or distraction. Anything that can direct her mind away from the pain. A picture, a focal point, imagery, music, maybe even the TV in some cases. Hydrotherapy is wonderful for back labor, okay? Just some tips on helping women through the contractions and their pain. So, with breathing, there's a couple of different styles of breathing. With the first stage, and we talked about the stages of labor, and the first stage, if you remember, is from beginning of dilation to 10 centimeters, okay? It's the part where they are working one of their hardest times, okay? The slow pace breathing, they're going to use in between contractions, okay, when they're resting or sleeping. The next two, the rate should never be any faster than twice the usual rate. But as you can see, all of these are going to be started with a cleansing breath, in through the nose, out through the mouth, and then depending on the intensity of the contraction will warrant or decide how quickly mom needs to breathe, or the pace that she needs to be breathing at, and then, of course, resolving that with a cleansing breath at the end. D is more pattern breathing that begins and ends, of course, with a cleansing breath, and it sounds something like this. In through their nose, out through their mouth, a nice cleansing breath. He, who, he, who, or he, who, okay? And again, ends with a cleansing breath. This is used many times when moms are feeling that urge to push. But all of them are used throughout the first stage of labor, depending on the intensity of the contraction and what it takes for mom to breathe and relax through them. That is why our role as a nurse is so important. It is during the second stage of labor that the pushing phase begins. Prior to the second stage, mom may start feeling lots of pressure, like she has to bear down and push. She may need to continue to use the modified pace or the pattern pace breathing to help her from pushing or bearing down. With the second stage, of course, we want her to relax in between each contraction. That slow pace breathing is going to be very important for her to completely relax her body. But with each push, we're going to have mom take a big cleansing breath at the beginning, and then take another deep breath and hold it for 8 to 10 seconds. Take another deep breath, hold it 8 to 10 seconds. Take another deep breath, hold it 8 to 10 seconds, and then relax with a cleansing breath. So with each contraction during the second stage of labor, we're going to have mom push at least 3 good pushes that last 8 to 10 seconds long. And this is a lot of work. One of the problems, if mom is not able to control or pace her breathing, she may hyperventilate. This is one reason why it is important for moms to go through childbirth classes, to give her an opportunity to learn the different techniques and to be able to practice them. Many of us, whether we have ever had a child or not, may have been in a situation where we felt anxious and started to breathe fast. The result of breathing too fast is hyperventilation. So here are the signs and symptoms. You need to know these, okay? dizziness, tingling of the hands and feet, cramps, muscle spasms, numbness around the nose or mouth, and blurred vision. Corrective measures, breathing slowly, especially when exhaling, breathing into like a cupped hand or a moist, cool cloth, or holding the breath for a few seconds before exhaling. And so you do need to know that both the signs and symptoms and how you can help mom correct hyperventilation. So part of our role is, if needed, to teach or coach simple breathing and relaxation. That's part of our role, okay? But the saying goes, if it ain't broke, don't try to fix it, okay? If mom is doing well, is safe, baby is doing well with non-pharmacologic pain control techniques, leave her alone. Don't run in there and say, okay, when do you want to get your epidural? Yesterday, okay? If she's doing well, support her decision, okay? Just support her during that time. Stand back, okay? She'll tell you when she can't tolerate it any longer, okay? So let's talk about some pharmacologic pain methods. Advantages, of course, it helps mom to be, hopefully to be able to, it helps her to relax better during the labor. It helps to reduce her pain. If she's not hurting as much, she may be able to be more of an active part of her labor. Drugs do not relieve all pain, but dulls the senses so that maybe it doesn't hurt as much and allows her to relax. One thing pain can cause is a stress response, which in turn can cause an increase in autonomic activity, causing a release of catecholamines, which causes a decrease in platelet perfusion. With this type of response, fetal acidosis can occur. With mom in pain and breathing rapidly, she's going to hyperventilate, which can lead to her respiratory alkalosis and then a compensating metabolic acidosis. With her going into metabolic acidosis, this leads to increasing or worsening acidosis in the fetus. So appropriate pain relief and relaxation is very important. We need to remember when providing mom with pain relief with analgesics or even anesthetics, we are medicating too. Any drug given can also affect the fetus. These effects can be prolonged in the fetus and even after they are born. They can be direct or indirect effects. Some of the effects of medications can slow down the labor. Some complications of pregnancy may also limit what methods or agents can be used. With epidurals, we need to use high volumes of fluid to prevent hypotension, right? This may put mom at higher risk for cardiovascular overload. It is important to know mom's history. It is important to know if she's been on illicit drugs because these could interact with the medications, the analgesics that are given. That is why that history is so important. So with narcotics, these include, of course, analgesics, adjunct medications to help analgesics to work better or to counteract side effects of anesthetics. Analgesics are usually given IV, and remember I mentioned with the increase in the peak of endorphins during labor in the mom, usually we don't have to use as much. But we want mom to remain conscious. She may drift in and out of sleep and between contractions, and that is fine. The most common analgesics that are used in labor are opioids. We want to give small doses, again, to avoid respiratory distress in the fetus when they are born. But we know analgesics don't always take the pain completely away, but it hopefully makes the contractions more tolerable. We also want to avoid using analgesics or narcotics if delivery is imminent, and I would say within an hour or so, because again, it's going to affect the fetus. What you don't want to happen is for the medication to reach its peak at the time of delivery. It can be given in later stages of labor if need be, but as a nurse we must be prepared for a very sleepy baby, one that does not want to put much effort into breathing. So some supplies so let's think about some supplies that you would want to have ready in case your baby was in distress. O2 face mask, ambu bag, suction. Okay. Narcotic antagonists actually reverse the respiratory depression, which is one of the effects of narcotics. It does not help, nor should it be used in a baby that is in respiratory depression or distress caused from hypoxia in utero. That's a totally different reason, okay? When given to mom who is using drugs outside the hospitals, it can also cause a profound narcotic withdrawal in both the mom and the baby. Okay, so antagonists, of course, reverses the common side effects of narcotics. They can also reverse the respiratory depression in both mom and baby. Of course, we would not, like I just mentioned, I'm kind of going back over this because I had paused the recording for a few minutes, so I want to make sure you get this. But they would not be used in fetal distress or fetal depression, respiratory depression, if those were caused by hypoxia in utero. Okay. Other adjunctive medications might be used along with narcotics to help minimize or alleviate side effects such as nausea. You do need to review in your book. I believe it's on page 165. I'm turning it to that just to make sure. Yes, on page 165, table 7-1, you do need to review these medications and their use and effects and know those for the test next week. So anesthetics actually cause a loss of sensation and pain. Okay? Regional anesthetics actually block the sensation from a localized area without causing loss of consciousness. General anesthetics are given systemically and also by inhalation, and they do cause a loss of consciousness and pain. One of the most popular anesthetics, and we all know that, are epidurals. It would not hurt to review your anatomy of the spinal cord. So think about, what is the membrane called that surrounds the spinal cord? I hope you're thinking meninges, okay? As your book states, the meninges has 3 layers: the dura mater, the arachnoid mater, and the pia mater, okay? The epidural space is where the anesthetic is usually administered, and this is actually between the dura mater and the bony covering of the spinal cord. It can also be given in the subarachnoid space with epidurals and or spinals. They both block pain and many times motor responses. Moms will describe their legs feeling very heavy and they cannot move them very well. Our role as a nurse is, of course, to assess and evaluate mom's response to the type of analgesia or anesthetic, and also the baby's response. Remember, as a nurse, whether you're an RN or LVN, it is never within your scope of practice to give anesthesia of any kind. You can assist by handing things to the physician, positioning mom, monitoring mom and fetal outcome, and reporting as necessary. The block may also vary, and this may, would depend on the type of block and the quantity of medication and the actual medications used, and that is, again, up to anesthesia. So vital signs: mom's blood pressure, fetal heart rate are very important to monitor. Another side effect of epidural or any type of regional anesthetic is urinary retention. So be thinking about what your nurse's role and interventions will be to monitor and alleviate urinary retention. On page 166, it goes through these different methods of anesthesia that can be administered for childbirth, and you again need to know these different types and know your nursing implications. Very, very important. Okay? With levels of regional anesthesia, this is a diagram, and it used to be in your book, and it still is on page 168, that describes the level of anesthesia that is desired for both cesarean and vaginal birth. And of course, you know, you want it a little higher on the abdomen for cesarean because of the pressure and the pulling that goes along with C-section. So typically, general anesthesia is not used for vaginal births, except, I guess, in a very, very extreme circumstance, okay? It is used for C-sections typically when there's an extreme emergency or if the mother refuses regional anesthesia. And again, like I mentioned, and your book talks about, it is a combination of IV medications and inhalation medications. Adverse effects to mom, regurgitation and aspiration of stomach contents, which can lead to aspiration pneumonia, which can be fatal. This is why mom is given a medication called Bicitra to neutralize the stomach contents and hopefully minimize the risk to mom. The adverse effects of the baby is respiratory depression. Because the drugs given to mom transfer through the placenta to the baby, we want to minimize this risk at all cost. All right. So if you are ever in a C-section with me during clinical and they do general anesthesia, what you're going to see is that mom is not going to be put to sleep or given any type of narcotic until everyone is completely ready, okay, including the surgeon and his assistants, the scrub tech, anesthesia. Everybody is standing there ready to go. They're going to induce anesthesia, okay, put her to sleep, and start cutting immediately and get to that baby as quickly as possible. The sooner we can get to that baby, the less likely that the narcotic or the effects of general anesthesia will reach that infant. If not, then we have to deal with a sleepy baby or a baby that is may have some respiratory depression. With either spinal or epidural, but especially the spinal, moms may experience what we call a post-spinal headache. Typically, this can be controlled with bed rest, fluids, and analgesics. If not relieved, then a blood patch is done by anesthesia personnel. This procedure includes drawing up, doing a venipuncture, drawing up 10 to 15 milliliters of mom's blood, and then they position mom as if she's going to get a spinal, and they inject into this subarachnoid or epidural space the 10 to 15 milliliters of blood. And what happens is forms a clot that seals over the puncture site where the spinal fluid may be leaking. Over time, this clot breaks down and, after the puncture site heals and is reabsorbed in the body. But in the meantime, it can give immediate or sustainable relief to mom's headache. So you do need to review on page, 170 about the blood patch and what this all entails and what your role is as the nurse in different pharmacologic techniques and therapies. So be thinking also, what is the most important nursing responsibility after an epidural or spinal block during labor and delivery? Okay, and hopefully you'll be able to answer that question in class on Thursday.